Thank you for staying tuned. We'll delve straight to the focus of the day. In the Niger Delta, health facilities are often the first point of contact for mothers, children, and vulnerable populations in rural communities. Yet many of these centers sometimes lack manpower, drugs, and equipment, leaving the most basic health needs unmet. Across Akwa Ibom, new initiatives are being rolled out to bridge these gaps. But to help us understand the progress is made, the challenges still ahead, and what can be done differently, we are being joined by Dr. Eno Attah. She's Executive Secretary of the Akwa Ibom State Primary Healthcare Development Agency. You're welcome on the program, ma'am. Thank you for joining us.
Thank you so much
Thank
for
you for
having
joining
me.
us, ma'am.
Thank you. Thank you very much. It's a great pleasure to be here. First time.
You're welcome. You're welcome for joining us. Thank you.
Yeah.
Well, Dr. Attah, let's begin with a snapshot. When you look at the activities of the primary healthcare,
Right.
let's start with Akwa Ibom now. Do you see a lot of improvement when you compare that to what has been happening over time? We moved forward, or there's still a lot of work to be done? We've seen the governor announcing all manner of things that are supposed to benefit primary health care and the rural dwellers and the hinterlands, grassroots generally. Is it really working?
So at first thought, I would want to say yes to all of your questions. Yes. And the reason why I'd want to do that is that for many years, let me call it decades, the primary healthcare facilities have been neglected for one reason or the other. And most of that has to do with the coordination and management. And so Akwa Ibom State was very fortunate eventually to have the immediate past governor, Mr. Odom Emmanuel, sign into law the bill that was advocating for the establishment of the Primary Healthcare Development Agency as a separate body, but still a parastatal of the State Ministry of Health. Because for a long time, the PHCs had been under the local government, and also different bodies. There were some programs that the State Ministry of Health was to handle. There were some other programs that were handled that, let me say, Ministry of Women Affairs. So you can imagine having many cooks and not having a coordinated approach. That really, really affected the PHCs, primary health centers, in Akwa Ibom State and across the country. So that is why the primary healthcare under one roof policy was brought up as far back as during the National Health Act when that came out. That was assented to, but Akwa Ibom didn't come on board with our PHCs until 2018. That's when we first came on board and had an agency looking solely and primarily at the health facilities. So that's why I said I will answer yes to all of your questions. So yes, they have been neglected. There had been a long period of neglect of the PHC facilities because of the lack of coordination of management, and therefore the planning and budgetary provision was not coordinated. So even if one body, one of the MDAs was supporting one aspect, you can imagine it wasn't covering everything. And then even the staffing and all of that. So now with the agency on board, we started making progress. And it looks as if progress is slow, but a lot is happening. I mean, when you see a duck in a pond or a body of water paddling away, they look so calm and peaceful on the surface, but a lot of paddling
It's going on
going
underneath.
underneath. And the fact that they were so bad to start with the lots of paddling that we're doing underneath, we'll start to see even more and more gains. But let me give you something personal. 2 months ago, on my usual just drop into a health facility unannounced, I went to one primary healthcare facility in Uyo in the Akalford area, and I was so impressed. I was impressed that not only were the funds, so because the state now set up the agency in the state, we were able to unlock funds from federal government, and they're called Basic Healthcare Provision Funds. That was also part of the National Health Act provision. So we're able to unlock those funds and now send directly to facilities some financing. We don't do anything with the money. That aspect that is called DFF goes directly to the health facilities. And under Basic Healthcare Provision Fund, one facility per ward, per political ward, is catered for. So we have 329 facilities that are receiving this funding. So it's like a special impress for them. They're supposed to get it every quarter, and then they can split it up in the 3 months of the quarter and do certain things. You know, nobody will give you money without telling you this is what you're supposed to do.
Indeed.
So they have a list of things that they're supposed to provide for themselves, you know, do up their facilities a little bit. But the funding they get, while it can cover consumables, when I say consumables, needles, cotton wool, all of that, maybe fixing a leakage in the roof, it can't renovate the entire facility. They can paint, they can provide curtains, they can, you know, those kind of soft things, and then they can also purchase drugs.
All right, Dr. No, when it comes to primary health care, you see, one of the problems people complain about, let's say, is affordability and accessibility.
Yes.
How accessible and affordable are most of these primary health care, you know, centers?
Okay, so accessibility in terms of being able to get there,
Being able to get it,
being able to
having facility,
have a facility
close by,
close to you, and get to that facility with the roads. This is my expansion of accessibility, because it's one of our tenets at the agency that we should make sure that we provide accessible healthcare services to our people. So that accessibility is not just being able to walk and get there, or drive in a car, or whatever modes of transportation, but the accessibility is, can you afford the care? So that's where the affordability comes in. So it's getting better. It's getting a lot better. And why am I happy to say that? Because currently, this present administration of His Excellency Pastor Omo Basieno, PhD, has brought out clearly to everybody that cares to go back and read the Arise agenda and the blueprint therein. He's brought out clearly that his main focus in the health sector is primary health care. And he's not neglecting the other tiers of health service, but the main focus is primary health care. And he's put his money where his mouth is by revitalizing PHCs across the state, and we expect to see a lot more. So you have this model PHC facility set up in there'll be at least one per local government, and he's going to build on that. So you have this model healthcare facilities, one per local government. So there's that level of improving accessibility. Then he is also supporting very strongly the state health insurance scheme. So that means that they can afford to go in there. So now I'm back to my story. No, I didn't forget. So back to my story of walking into a health facility in Uyo and seeing that, you know, there was this lady that brought her newborn baby for immunization. First of all, she's been taught, she remembers that she should bring the child back in for immunization. And so it's accessible. And I was saying to her also, you had your baby here? She told me about it. And then the officer in charge said, she's one of the enrollees for health insurance. So that woman didn't have to think about the costs. She just came into the facility because she had her card. She was attended to, she had her baby there, and brought the baby back. And because that's a newborn under 5 years, that baby will receive free care.
All right, well, Doctor, let's look at statistics put out by the motherboard of this agency, which is the NPHCDA. In 2023, it said that less than 20% of primary health care centers are fully functional.
Right.
I don't know how much that statistics has changed, but then when you compare Kwaibom now, would you say that it has done enough towards ensuring that there are centers that are fully functional for these different primary health centers that we have to be working with to discharge the services of health?
Okay. So in terms of, I think that we have done a lot since 2023. A lot has gone on. So beyond the model primary healthcare facilities that have been newly built, and please bear in mind that they are not just newly built arbitrarily. We have different levels of health facilities. We have the ones that we call health posts that are in rented buildings. Sometimes you see them in council hall or church hall, or, you know, so sharing some hall with the school. So those are not government-owned. When I say government, health sector government-owned facilities. The community has just said, we want a post here, we'll give you this space. So what His Excellency has done is to upgrade those posts and now make them, so they're coming from 0 to 100. and make them the model healthcare facilities so that the numbers are not over-bloated, but we're improving on what is already on ground. So when you say, has it done enough, is it ever enough?
As long as it's covering the persons who are in need of it generally.
Yes.
If it's not enough.
So a lot more people are able to get that accessibility to healthcare services at the primary care level because of this combination of things. Building of new facilities, like upgrading already existent lowest level facilities to the highest level that you can get. And also the health insurance that has come into place. Do you understand? So that the woman is not thinking, yeah, you do understand, she'll go to the facility, they'll tell her how much for card, first of all.
Also the conversation around how subsidized that health insurance is. You want to speak on that?
Well, do you want the executive secretary of the state health insurance to speak on that? Because I'm speaking on my component. But really, it's supposed to be such that you walk in once you've enrolled. And these are for the vulnerable groups, the children under 5 years, the pregnant women in the society, and then the elderly above 60 years. They are not supposed to be charged at all. Now, you and I, if we want to get state health insurance, of course we can enroll, but there's a premium for that. But the ES of the health insurance would be the best person to talk extensively on that. So there's that aspect of the new builds, right? But then there's also the aspect of renovating the currently existing health facilities. So the federal government, this is where the federal government comes in. For now, for us at the state, I'm sure that His Excellency will also extend between building new and then renovating the currently existing. So the federal government, through, once again, the Basic Healthcare Provision Fund, has given the states funding to be able to renovate existing facilities. Unfortunately, Akwa Ibom was not one of the ones that took the World Bank funding to do this. So we only have a limited amount to work with, but we're able to renovate 4 health facilities across the 3 senatorial to start with. Me, I'm not waiting until you can do all before I'll collect. Oh, you want to give me 5, please. 3 from you, because everything adds up.
While continually asking and putting out the requests.
Yes, exactly. You know the modus.
All right, Dr. Now let's look at the issue of traditional birth attendants.
Yes.
You know, they are closer to the people also.
They are with the people.
With the people, and there have been lots of effort trying to dissuade people from making use of traditional birth attendants. Are there any effort to ensure that they upskill these people and make them up to standard?
Oh yes, there are. There are many efforts with our traditional birth attendants. First of all, it's not to the way our approaches, especially at the primary healthcare level. It's not to castigate them and chase them out of the way, because there are issues with some of the practices, and you can understand. I was able to visit China about 4 years ago on a preventive health trip, and they showed us the cohorts that went. They showed us how they run their own traditional Chinese medicine. First of all, we were staying in a medical school, and they were in that medical school. So it's like everybody comes in, you sit for JAMB or whatever it is that they do there. Everybody comes in on the same level. You take the first year, courses are the same across board. It's only by the time you get the second year or third year that you now differentiate. So you can imagine they have a well-documented system. We don't. You know we don't. We don't. So even if
issues of data, right?
Data, yes. So even if you say, oh, my mother used to do it like this, what was the dosage of what your mother used to do? And there's another thing, Chinese whispers. If I whisper something to you and you tell him, and then he tells it back to me, it will be different from what I told you. Just because we filter it. So your mother told you this, then you now filtered it and this is what you're doing. Is it the right thing to do? Is that what she actually did?
Which now underscores the importance. Of data and documentation.
Exactly. So with that, sorry, I get it very,
I
get carried away.
It's all right.
So with our TBAs, especially with, there's a program that we had been working with from the National Primary Healthcare called the Community Health Influencers Promoters Services, the CHIPS agents, that we were only able to carry out in 6 local governments. But through that program, we're able to reach out even deeper into the community, and we're now revising it with the national to community-based health workers. Now they know the ins and outs, they know all the TBAs, they have their listing, And then we bring them out, we give them commodities to use, gloves, because even they are at risk. Imagine delivering a woman who might be HIV positive with your bare hands. And the way they cut the cord and handle the placenta, they're also at risk. We have some TBAs that we've tested. Do you understand? So we try and give them commodities, give them some light training. Doesn't mean that we're expecting them to carry out any cesarean sections, for instance. But please, the women that register with you, direct them to the facility for their immunizations and things like that. When you see a case, when it gets to this point, please don't attempt. You know, actually, we can deliver by ourselves with no assistance. With no issues whatsoever, a woman can actually deliver by herself. But it is in the instance where there's a problem that you want to be
more careful.
And have a skill, what we call skilled birth attendant.
All right.
With you.
Well, talking about maternal and child health, when we talk about the mortality rate currently, where is it? Is it more regularized? Is it more controlled currently?
So that's what we're working on, my brother. We're working on controlling the levels. And another federal government initiative, that's something that we're working on now, called MAMI, which is the Maternal and Newborn Mortality Reduction Innovation Initiative. There's always a name, but the idea is that we want to bring down the rates of the maternal mortality rates and the infant mortality rates, the neonatal mortality. Neonatal is that in the first 30 days of life, but infant obviously is older than that. We're trying to work on it. Life is dynamic. There's always something happening, but we're trying to work on it. So this initiative from the federal government that has been started out in some states, including Akwa Ibom State, I believe it was the first week of August that we actually had the program officer, the national program officer, come in with his team, and then we sat down together. We went through the assessments of the different health facilities and proffered our solutions. So working with that, you see, we're attacking this thing from every angle possible. So we're working on it. It's a work in progress.
All right. Well, I just want to get this off my chest. Now, the World Health Organization says that they're recommending 23 health workers to every 10,000 patients. And when we look at what's happening in Nigeria, it might seem as though we don't have even 4 to 10,000. I'll still localize it since you're representing Akwa Ibom now. Do you think that health workers are more engaged currently at the primary healthcare level?
We're asking for a lot more to be engaged. It's in process. His Excellency has made a pronouncement about recruitment. I want to say even more recently, but he's been talking about that, and the process has started where young, unengaged people in our state should register on the portal online. I'm sure you're aware of this registration going on. So we've also looked at it for the health sector. He's approved 1,000 staff to be employed, and we're going to prioritize according to the need. That's what we're doing. The Honorable Commissioner of Health is at the top of all of that. We know that, so you can imagine, if you're looking at the need, you have the secondary health facilities to cater to. We have about 42 secondary health facilities. And I told you in passing that for the funding that we're getting from the federal government through Basic Healthcare Provision Fund, we have 329 facilities, because it's one per ward that we're working with. But we have more than that. We have about 468 thereabouts primary healthcare facilities.
And you need to fill them up with.
We need to fill them up. So you can imagine the formula that we're trying to use to ensure that we have. But we actually want to ensure that for the first time in Akwa Ibom State, we have, I don't want to say, okay, for the first time with primary healthcare under one roof, because there was a time when we used to have doctors at the PHCs. So for the first time under primary healthcare under one roof, we're going to get at least one doctor per local government. Do you understand?
Okay.
So
one per local government.
At least one. So that doctor in the local government will take care of all the primary healthcare facilities in that local government. They just have a roster and divide it up into days that they will be able to go and attend to any cases that need a doctor that were not urgent. But if it's urgent, obviously, I have to go.
Still makes one cringe, wondering
know.
if,
Yeah,
if,
one.
if one is enough.
One is enough.
It's not. That's the way I said. Is it ever enough? Is it ever enough? It's never enough.
All right,
But because it's not enough, am I going to say no? You can't give me only 31. No, I want. Do you understand? Yeah.
All right, doctor. Let's look at the health insurance. We have the state health insurance agency and also the national national health insurance agency. To what extent has this agency been able to bridge the gap with universal coverage, universal health coverage gap?
Back to my story. So imagine that one woman. So when we talk about rates and mortality rates and this one, and we're talking about numbers, those numbers represent people. That's what drives me. Those numbers represent people. And if one person has been able to access care through health insurance, we've done a lot. Do you understand? One person, one woman, one pregnant mother at a time. So I really, really appreciate the fact that we have now on board in the state health insurance agency. I'm very thrilled about that. So you know what that's going to do? It's going to give more people access to assess the services that we're trying to improve at the primary health care. Imagine if His Excellency pours all this money in, and even if we get all the doctors that we need, and patients still look at this facility like, I don't have the money, I'm not going. But if she has a card that says she has money, she can access. That's universal health coverage. That is not going to be at a cost to her that will probably render her, onto deeper poverty line. So I think they're doing it.
All right, Dr. Eno Attah. I'll just ask you one parting question. And I always like bringing this question up, especially when I speak to medical experts like yourself. And that's the issue of brain drain. A lot of skilled hands continue leaving the country in droves, and it raises cause for concern. And also issues regarding what the government is really doing, the different strata of government. What are they doing towards ensuring that they arrest or tackle the issue of brain drain and keep our skilled hands here in the country?
You're a young person. What do you think they should do?
Well, I'm the interviewer.
I know, but I have a question. I have a question. Before I go on to answer, what do you think? I want to hear from, do you understand? So that the next time I'm sitting at a policy level.
I wish you had that time.
Also, you have no ideas. Why are they leaving? They're leaving for...
well taken care of.
Thank you. I thought you'd tell me, take better care of them. That is what we need to do. We need to match. And sometimes it's not about money. It's about the fact that I have children, but I'm a doctor, I'm a nurse, I'm a midwife. I have children, and they need to go to school. Do you understand? And the same markets that everybody else is going to is the market I'm going to. So is that my money able to afford me? But if you give me incentives, for instance, all these facilities that His Excellency is building, he's going to give rural allowances to the doctors that agree to stay there. He's going to do that. If that's part of the plan. So if you're sent out of Uyo, instead of thinking, oh, in Uyo I can't get what I need, but you're sent out there, you're compensated. I have my own personal ideas. I don't know if I should share my personal ideas. That's why, but you didn't want to share your personal ideas with me.
We would love to hear your ideas. I mean,
my
that's
personal
the essence
ideas.
of
I mean,
problem.
it's not about the government forcing people not to go. It's let's come to the table and talk about this clearly. In other countries, in other climes, they beyond the maybe 1 year youth service, they negotiate because it's actually cheaper to be trained in a country like Nigeria and trained very well compared to, imagine if they had to pay in dollars for that education. Meanwhile, you hear all around that, oh, Nigerian doctors are one of the best abroad because of the training that we get. Do you understand? But if I come to a place where it's just a mud hut, am I able to use all of my training there? Do you understand?
Well, Doctor, do you think making the atmosphere, the environment where these doctors work more creative and more convenient, will that encourage them to stay?
I think it
more?
would. I think it would.
We hope it does. And thank you very much, Dr. Eno Attah, Executive Secretary of the Akwa Ibom State Primary Healthcare Development Agency, for coming on the program. Appreciate your ideas and how jovial you've been on the program. Thank you.
Thank you, Doctor, for coming around.
Thank you for having me. I think after this first instance, we will be coming back.
We'll hope to have you again. Thank you.
Thank you.
All right, so that's the size of Niger Delta today. Thank you very much for being with us. It is the weekend, and we're hoping that you have a terrific one. My name is Xavier Robert.
And I remain Siphon Ode. Good afternoon.